Hi, welcome back to NalaTalk, where we discuss about the field of genetics testing and its use in clinical practice. This week, we'll be discussing again with Dr. Esther, and with Christmas around the corner, we were thinking of talking about cholesterol, and with all the feasts that we're going to be having, and how to control it. So one of the important topics or important drugs that's been used to actually control cholesterol is actually something that's called statin. So before we go into deep into this, let me just greet Esther. Esther, how are you today?
Hi, Fad. How are you today? I'm very good, thank you. How are you? I heard that you've just had a holiday.
Yeah. And then this topic was very close to my mind, thinking of like all the fatty food I've been eating.
I think it's well deserved, though. Like you get a pass if it's your birthday, isn't it?
Yeah, that's what I've been telling myself too.
Exactly. No, such an important topic as well, because just wanted to touch on a broader topic of cardiovascular heart disease, and how lipid or cholesterol gitu kalau di Indonesia gitu kan dibilangnya is just one of the modifiable risk factors, meaning that we can do something about it that can impact our health in the long run. So that I think is very important for us to talk about that. Apart from cholesterol or lipid levels, there are other things as well that that we can do better with in terms of improving our health. That would be to stop smoking, because smoking is really bad, and it will actually cause clots. It can cause cancer. It can worsen all the other risk factors overall. Just that is backed by evidence. And then another thing would be to increase physical activity, because physical inactivity is also linked to greater risk of cardiovascular disease, and also poor diet. Like one that we can touch on again with the topic today would be high sort of cholesterol, high fat diet. And as you mentioned, statin is one of the most commonly used medications used to lower the levels. Tapi it's very important for us to also help by doesn't mean that we have this medication and then we can just go and eat anything that we want to. Tapi kita juga harus help by exercising more self-control and also employing a healthier diet overall. Just sort of a PSA to get it out there. Yes, so statin we use widely, especially when I used to work in the internal medicine department as well as in the stroke department. We use high dose statin, especially for people who came in with sort of heart attack or a stroke. We will put them immediately on high dose statin, and a couple with other medications as well. And also it's used in GP as well. So in general practice, used in both primary prevention and a continuation for secondary prevention from when they were admitted to the hospital for the acute attacks. Jadi, maybe I want to get a general overview nih. How does statin help in general? I thought maybe you can also with that give an overview of why is cholesterol bad for in clogging up those arteries?
Yeah. So before that, all the recommendations you've given me was super useful. I think I need to follow that. Like,
I need to follow that too.
Reduce the high fat diet, etc. So yeah, and then talking about cholesterol, we always hear that the media or like almost everyone or even the doctors also say that cholesterol is bad for you. But what exactly is cholesterol, right? Cholesterol itself actually has different types inside our body, and ranging from like high density lipoprotein, low density lipoprotein, and even triglycerides, right? What people usually mention or refer to for bad cholesterol is what we call as LDL, or low density lipoprotein. And the reason why low density lipoprotein is in high levels or is bad for us is because these molecules, as its name, like low density, right? It actually floats around inside our bloodstream and has a tendency to actually stick on the inner side or inner surface of the blood vessels. And when they stick to each other as well. And in high level, they can actually create a clog inside this. And this is what actually is the precursor or the first step of getting a heart attack, where the whole blood vessel can get blocked by these cholesterol. So that is why it's actually bad in high levels. So the reason why we want to reduce it is because to reduce the chances of a heart attack. And how do we reduce it? There's a lot of different mechanisms, from non-pharmacological to pharmacological. Of course, the easiest way or the most easy way to answer is to actually reduce your intake of cholesterol, right? Because when you eat less cholesterol, there'll be less cholesterol inside your bloodstream. But sometimes pharmacological method actually can help reduce this LDL further. So one of the pharmacological options is actually called statin. Statin is a family of drugs that acts on an enzyme that is called HMG-CoA inside our liver cell. So HMG-CoA is actually an enzyme that changes a precursor, a molecule, into cholesterol inside our cells. So in our cells, in our liver cells, actually cholesterol is being constantly produced because it's actually one of the source of our energy, as well as for other cell signaling as well. So inside the liver cells, cholesterol is actually produced. In order to be able to reduce the level of cholesterol inside our bloodstream, we need to be able to trick the liver cells into thinking that they don't have enough cholesterol, so that they will actually bring in the cholesterol from the bloodstream. And statin does by just that. What it does is that it actually blocks the enzyme that converts and produces the cholesterol, such that there will be a low level of cholesterol inside the liver cell. And when that happens, this cell will try to compensate the reduction in cholesterol by bringing in LDL from the bloodstream. So how this statin works is that once that cholesterol inside the cell is reduced, it will bring in the cholesterol from the bloodstream. Okay.
Yeah.
So, yeah.
Great. Thanks so much. I feel like it just brings me back to just sitting in the lecture theater and have someone explain the pathways, and how the statin works. Thanks so much. I'm sure there are a lot of other factors as well that goes into the choice of statin as clinicians. And one that I most frequently encountered would be like simvastatin. Not simvastatin, atorvastatin and rosuvastatin. Those are the ones that were commonly used from my sort of clinical days. But there are other considerations as well, apart from the renal function, and the effectiveness of the statin, which would be the genetic variations that exist in the
the choice of statin. The first consideration is actually what kind of intensity of therapy you require, right? So it's actually right now separated into three categories, like low intensity statin, to medium intensity to high intensity. So, for example, simvastatin, something that is most commonly prescribed by GPs, the family doctors, are usually the low intensity statins that actually is used as a primary prevention of cardiovascular disease. So simvastatin 20 mg is one of the examples. In contrast, for a high intensity, could be like rosuvastatin 20 mg, atorvastatin 40 mg, something like that. That will be high intensity. And these are for those people who have already had a heart attack probably and want to prevent further heart attack in the future. So that's one of the choice that we want to consider first.
Yes. Great. This is why it's always nice talking to a pharmacist, because they can always give the best advice. The other things would be just to sort of highlight, because obviously with every single medication, we look at the risks and benefits. Now, some of the things that we always advise patients would be the side effects, of medications. And with statin, commonly would be kind of myalgia, and that would be sort of aches and pains in the muscles, but that can deter people from continuing the treatment. So it's important to always counsel them that this is something that can happen as well, and do take note of it when it does. But also a more serious one would be kind of myopathy, where you get sort of muscle breakdown, and you can also check sort of the levels of the creatine kinase in the blood. And also most severely, it can cause sort of rhabdomyolysis as well. It can cause sort of acute renal failure, which would warrant a very serious and urgent interventions in the hospitals to prevent it from getting worse. But yeah, those are some of the side effects that we normally caution patients. And with that also, we do regular monitoring in terms of checking their liver function, because that can also elevate the sort of some of the enzymes, and also to monitor those creatine kinase levels. Now, in your experience as well, but what are some of the, since we're talking about pharmacogenomics, whether there are any sort of genetic variations that can make this worse as well?
Yeah. So the side effects of statin, what we usually call SAMs, right? Statin muscle-related adverse events, are actually usually quite linked to the level or the blood level of the statins inside our body, or plasma level. So this, so that means it's actually related to the transportation and metabolism of these statins. So what we know is that the statin intake into the liver cell is actually controlled by a transporter enzyme, that is a transporter protein that is called SLCO1B1 or OAPP1B1, that is actually functions as a door for the statins to enter into the liver cells to actually use out its function, right? So when it goes inside there, it can actually exert its function. So if there's any mutation or changes or polymorphism in this SLCO1B1, there's actually going to be quite a change in the uptake of the statins into the muscle cells. And when the uptake into the muscle cells is reduced because of the door not being functional as it's used to be, there's going to be an increase in the blood level of the statins, which may cause the increased chance of myopathy, because instead of going into the liver cells, these statins could go into the muscle cells, where they can actually affect the synthesis of like coenzyme Q10, as well as it can actually affect, cause like autoimmune kind of effect that can cause the myopathy and myalgia as well. Yeah, so one of the most important for statin genetic variation that we have found is that actually there's a variation in SLCO1B1.
Yeah. So would you advise to test people for this gene, and maybe like other biomarkers that can help in determining which one would be the best or which one would to avoid?
Yeah, I would say, would I advise people to test for SLCO1B1 alone? I wouldn't say so. Don't test for it by itself, because what we need to know is about the likelihood of it happening as well as the cost effectiveness, right? What we know in Asian population, the polymorphism for SLCO1B1 is not as high as the general population, like what is in the European or the American. But having said that, it's always good to know kind of information. And if we can find it out together with other kind of genetic information, why not, right? It will actually help out in the future. Just say that if you are one of the unfortunate one to have a mutation in the SLCO1B1 gene, you don't have to go through the predicament of like having to experience the muscle aches should you need statins in the future. And they can actually choose the statins that have lower likelihood of causing myalgia. Yeah.
Yeah. hopefully in the future, when we have more information about like which different biomarkers, and as we have we find more association or links with regards to statin and the genetic links to it, then we can advise people as to maybe there can be a test that they take preemptively to determine that. But yeah, along with other sort of graph panels as well, so they can just test it once,
Exactly. Yeah.
Yeah. Great. I think hopefully people find this helpful. Statin is just one of the medications that we talk about when we discuss sort of the cardiovascular risk factors and how we modify it. But there are actually other medications as well. I think that you mentioned previously as well with regards to triglycerides, Fadhli. Yeah, and also the non-pharmacological interventions as well. Hopefully, with this in mind, our viewers, whether it could be like doctors or patients alike, could take this and I guess be more responsible when they go out and party and have a great time with their families. Everything in moderation. But just be cautious of what you're eating. Just make sure that you consume nutritious food. But yeah, every now and then, especially if it's your birthday, like you said, I think it's okay to just splurge a little bit. Yeah, do you have anything to add to that?
Yeah, I think you've covered it all. So what we want to do is we want to make our audience to start the conversation, right, about the effect of like cholesterol, and also they be able to take the responsibility as well as the ownership of their own health, to know what they're taking when they need to take medicine, what they're taking, and how do they actually reduce the likelihood of having adverse effect when they take the medication. Yeah, that's all.
Yeah, great. Thanks so much. Really nice chatting to you again. And thanks for tuning in. We will see you on a later episode of NalaTalk. Bye.
Thank you. Bye.